my name's Kelly Dobbin. I'm here wearing two hats today. I am the Registrar and CEO of the College of Midwives of Ontario. I'm also a member, or we at the College of Midwives, we're members of the Canadian Midwifery Regulators Council, and some of our other members are here today representing their jurisdictions. So yes, Ivy and her team approached midwives. I don't know, maybe 2 years ago now, Ivy, maybe longer. And there was a lot of interest on our from all of the midwifery regulators in every jurisdiction to be a demonstration partner. And we had our own jurisdictional needs, but also just as a council, we thought that this was obviously the right way to go. We although as regulators, we aren't directly responsible for health workforce planning. It's not part of our mandate per se. However, we recognize that we're partners in this, that we're the ones who hold much of this information and the data around practicing midwives in our jurisdictions. And we recognize that, yeah, we can help. We also, like many of you, I'm sure, especially coming out of the pandemic, we've recognized that burnout has been a big issue in our profession as well as yours. And yeah, we recognize the downstream effects of burnout on clients and the safety and provision of the provision of safe care to clients. And so we felt that this was just being involved in the health workforce planning space was going to help us protect the public in a better way. So those were some of the reasons why, just several reasons why we became interested and why we wanted to be one of the demonstration partners right from the get-go. So where are we at with the implementation of the minimum data standards? So we're all very small regulators and none of us have access, or few of us have access to substantial resources to make database changes. So we're all at very different stages. Some are just thinking about it. Some are starting to put plans in place. As far as I know, that none of us have actually implemented it as of yet or finished the implementation. I can speak to where we're at the College of Midwives of Ontario. We have a database that we are actually migrating to a cloud-based database. It's the same database vendor, but we're making improvements this summer. And so this is on our project plan to make the changes, implement or utilize the new minimum data standard in our own database. And we expect that, knowing that this takes time, we're expecting that it will be in place for our renewal, our annual registration renewal in October of 2025. It's going to be too tight to have it completed for October 2024 because we launch August 1st. We open up our registration. So couldn't meet that deadline, unfortunately, but we do think that we'll have it for actually new applicants who apply to us around this time of the year, sort of spring, summer, and then also the October renewal date. So we're excited about that. We do think that by collecting this information, we know that we'll be owning the information for now. We're starting to talk about whether or not, as other midwifery regulators come on board and start collecting that information, where do we store, can we share that? Is there a place to store that? And I know that we've had initial, ideas from Ivy and her team saying, well, there are definitely places that data can be transferred and stored responsibly and shared with researchers should we want it to be accessible. So we're just at the beginning stages of having those conversations and probably won't really have those conversations in any depth until until we've actually started collecting this data. In Ontario, we're really hopeful that the ministry, through their health workforce planning branch, will adopt this new this revised minimum data standard for their collection purposes. We are required to report into the health professions database. And I know Ivy and her team have been in conversations with them. So we're hopeful that that's happening or that's on the horizon anyway, so that we can share this, more robust data with them, and will contribute to the provincial planning that we hope will take place. So we're happy to contribute to that. And then also sort of looking internally, at our own college. We're looking at this as part of like an equity initiative. So we're looking about how we can understand our own regulatory systems, programs, and policies, and how they can be analyzed and improved from an equity perspective. So all of you know that good policy development includes equity impact assessments. And then I think the meaningful demographic data that Ivy was just sharing with you all will help us understand our registrant base better, our applicants better as well. And we're hoping that will help to inform our own policy development at the college, and also allow us to conduct targeted consultations with specific registrant populations to ensure we're developing more equitable policies. I just want to make sure that, I think you might have said this, Ivy, but we're looking at collecting that information on a voluntary basis. It won't be required for now. We'll see where the world goes in the future with that, but for now it would be on a voluntary basis to provide us with that information, and for us, to collect it. We're also looking at it's our responsibility to make sure that our programs and the services that we provide are equitable. We know that right now they're really more designed to be fair and equal, so that every registrant is treated the same way. Let's say it's through our investigations and complaints programs or our registration activities. But we're hoping that this data, the demographic data, may give us some additional insight as to whether or not there are inequities in our systems and our programs. So whether or not, let's say, for example, racialized midwives are treated differently, or there are different outcomes of panel decisions in investigations and complaints, those sorts of things. I mean, of course, we hope not, but if that is identified, then it's something that we're responsible for, and we need to take action to correct that. So we're looking at both, contributing to the health workforce planning in that sense, on a national basis, on a provincial basis, but also looking at our internal systems. We're hoping that this data will really allow us to make improvements and be more responsive in that way. So if anyone has any questions, I don't know if you want to open up for questions now or after Adam presents, you let me know, Ivy. I'll take your lead.
Yeah, thank you so much, Kelly. Really appreciate that update, and how you, as a demonstration project partner, are looking at implementing this. So yes, if people have questions, please put them into the chat. I have some items that I'll follow up on, but I would like to hear from Adam next about the experience of medical laboratory technology professional regulators. So Adam, over to you.
Hi, good morning. My name is Adam Chrobak. I'm the Registrar and CEO for the College of Medical Laboratory Technologists in Manitoba. I'm also the current chair of the Canadian Alliance of Medical Laboratory Professionals Regulators. I normally work and live on Treaty 1 in Winnipeg, which is also the homeland of the Red River Métis Nation. Currently, I'm visiting my mother in Surrey, BC, so I'm not sure what territory this is. I should know that, but I don't, sorry. Yes, a lot of what Kelly said is a lot of the same for us. So I might be repeating what Kelly said. Sorry for that, but I think we all experience the same things, no matter what profession we are. So I started as a registrar back in 2010. Looking back now, that seems, for me, it doesn't seem that long ago, but when you think about it, it's almost 15 years. I'm starting to be the old guy around the block. That wasn't the case back then. We had a very, very minimal HR data set that we were required to provide to the Manitoba government. And at that time, the government's view on our responsibility, and I'm speaking in Manitoba, I know other jurisdictions have different responsibilities from their government. We were not expected to participate in anything related to human resources. We were only supposed to be collecting data related to regulation. There were several occasions where I was reminded of that when I was talking to the minister about critical shortages. We were also required, we still are required to collect data related to care registration practices. And back then, we also had an agreement with CIHI, and we had approximately 50 plus data points that we identified as MLP regulators would be potentially important to us. Now, all of those different data dictionaries did not align, and it made it very, very difficult for especially colleges like ours that have limited resources. So when I heard of Ivy's team's project of creating a minimum data set, I was excited because at the same time I was working with the Manitoba Health Human Resources team, and they were trying to develop their own minimum data set, and I kept insisting that maybe they need to talk to Ivy because they're talking about the same things. And it didn't make sense for me to be having two different data sets. You should have one. It makes more sense. It's more efficient and easier for regulators to do. Unfortunately, the provincial health human resources data team has been disbanded. I'm not exactly sure what happened. We lost contact with them several months ago, and only recently we found out that it was disbanded. So, two things that are important for me specifically is that College of Medical Laboratory Technologists Manitoba is in the process of transitioning to a new act, the Regulated Health Professions Act. This means there will be different data to be collected, and I will need to update my database to collect that data. And I'm planning to use the minimum data set to during the implementation of the database update. So those database points will be changed to be more in line with the minimum data set. One of the other things that I wanted to comment about that was that our original legislation required that we collect, and it was called sex, which means I'm from science, so it means the binary male, female. It's based on your genetics. But back then, a lot of people felt sex was kind of a harsh word, so they used gender. Now, gender means something totally different. And the RHPA still use the term sex. We recently have received a decision from Manitoba Health that we can interpret the word sex in the regulation, the new regulations, as gender and collect whatever data we would like. So I think we will be moving in that direction. I haven't had a final decision from council on that. The other important piece was I am also one of the project leads on the CalPER project called the Flexible Pathways to Registration for MLTs. This is a big project trying to find ways to help internationally educated get registered within Canada. Obviously, that project needs a new database to collect all that, and we are using the minimum data set for that project's database. The other MLT regulators across Canada are either looking at how they can use the minimum data set or are in a similar position as me. We're trying to implement them within our databases. And as Kelly mentioned, we all have limited resources, and I'm sure we all know IT support to change databases or even minor changes can get relatively expensive. Early on in the pandemic, I updated to the cloud-based version of our database, and at that time I was lucky enough to be able to get a CEBA loan. That helped a lot. I'm sorry, Kelly, you missed out. And you know, the government has, like Kelly's mentioned and Ivy's mentioned, the government has changed their view on regulators and their role in HHR planning. Like I said earlier, in the past, we weren't allowed to go in that area. Now we are not only encouraged, but we are required to start collecting the data. And a lot of the data in the minimum data set, we can easily incorporate within our processes. But like Ivy said, some of the data points will be by survey or a voluntary question on our registration. I think that's about all I need to say for now. I could keep going on, but I would like to leave early today.
Thank you so much, Adam. I really, really appreciate it. And so for those of you who are in attendance, if there's anything that resonates for you, please, put comments in the chat. Please, please, unmute. We're a small enough group. We're not on one page, so I may not see you. So do use your electronic hand, or you can always just unmute and just ask me to discuss while you are contemplating items that you can ask or comment on. A couple of things that I wanted just to provide some feedback. The comments both from Kelly and Adam mentioned the changing roles of regulators, and I think that the governments have been much more active in requiring regulators to do certain things, streamlining pathways for internationally educated health practitioners, and also just to be much more involved in the data collection process to go towards health workforce planning. Again, not to say that that the regulatory authorities would do health workforce planning, but they play an important role because you are in contact with registrants. And in guidance that we were asked as a technical research team, when we were contracted to undertake a review of health practitioner regulation for the WHO, one of the elements of the guidance was to optimize registry data for health workforce planning. So that's a very important element that is coming out of the WHO, which comes from a review that members of our team have undertaken. So that's really important. There has been a change with them. Other issues that were common across both midwifery and medical laboratory technology is issue around changing data collection tools. So that is really important. That's where we really want to go to with the technical guidance. So really hearing from regulators or different organizations who would be collecting data about what those technical implications are would be really helpful for us to hear so that we could develop guidance. And guidance we're agnostic to different providers of services for IT, but we would want to collect something that would really minimize single regulatory authorities in each jurisdiction having to do that. So if you could let us know what are some important considerations in that regard, that would be really helpful for us. Kelly and Adam also raised the issue of data collection burden. And so having to provide data to your ministry, having to provide data to CIHI if you have a data sharing agreement with the Canadian Institute of Health Information, and about the nuances and differences between what those are. Our hope is that we are co-developing with different partners a minimum data standard that can be adopted by provinces and by the Canadian Institute of Health Information. That is our hope. That is our intent. This is not a theoretical project. This is a very practical project that we are working in partnership with you. We want this to work for you, so we need to hear from you in these dialogues. What is it that we need to take into consideration? Issues around the sensitivity of certain demographic information, and so Kelly and Adam both raised this. In our minimum data standard, there is always a prefer not to answer category. So it makes any of these data elements voluntary. And I think there needs to be some understanding of how these data are going to be used. This is the same with Indigenous identity, or similar with Indigenous identity, of the use of the data. And so this is a process that is going to require building of relationships, building of trust, so that people feel comfortable identifying any of this information, because it will be similar with disability status, it'll be similar with ethnic identity. So I think it's really important to kind of highlight that at the outset. This is a standard that we want to be working towards, and we appreciate that implementation is going to have a variety of different considerations. Yeah, I think those were the main points that I wanted to raise, and I'll just maybe have Kelly and Adam, and in whatever order you'd like to do that, to say a little bit about what it's been like being a demonstration project partner, how much time has been spent on this, what would be considerations for other demonstration project partners to take this on. So I'm wondering if you could kind of both speak to that, just so that others know, what they might be getting into in that regard. So Kelly, go ahead.
Yeah, I would say it's been quite easy. You've made it really, you've been reaching out to us regularly, coming and making presentations to our national organization. We've just been in a listen and learn, but we're also feeling very heard too. If when we have questions, you're ready to answer them, and if not, getting back to us, which has been great. So it hasn't been burdensome at all. In fact, I feel like it's a heightened level of the conversations around data collection at our national table, where we want to go with this. We're a very collaborative group. I'm assuming others are as well, but we all get along really well at the national table of the regulators of midwives, and we're all really supportive of one another and wanting to help each other out. So it's felt very collaborative. It's felt very exciting. And so, yeah, it hasn't been burdensome. I don't know what else to say. And I feel like we always know who to reach out to if we have questions. So
that's great. Thank you so much, Kelly. And Adam?
for me, I didn't even notice there was a difference personally, because when I'm using it for our projects, it's just another reference document that I'm using as I'm trying to build out my database. I'm generally more hands-on about my database, but I can't speak for the other MLT regulators across Canada, but I believe we're all in still the exploratory phase. We're trying to figure out how can we implement this within our own databases, and then I think the Alliance needs to sit down, especially once the Flexible Pathways project is completed. How are we going to be using this data? We are currently implementing it within the database that we're building for the Pathways project. And the other ML2 regulators will have access to the data within there. So I think we're still in a wait and see kind of exploratory phase, but personally for me, I didn't even notice there was a burden. It's just regular day-to-day work.
That's great. That's great to hear, Adam, because we were really trying to be mindful of not adding work to our demonstration project partners. And it's really important to become a demonstration project partner. You can choose whatever scale you would like. So in the case of midwifery and medical laboratory technology, the consortium and the alliance came on, which brought all of their regulators together. In the case of medicine, for which there are no minimum data standards in Canada for medicine, I was really quite surprised when, Sarah brought that to our attention. It's the Ontario Medical Association that's doing it. In the case of physiotherapy, I believe it's 5 or 6 regulators that are working on it. And essentially what you get is a large Excel file with lots of details in the Excel file. And we just ask you to add a column and to provide some feedback on the specific data elements. It's organized in the modular fashion. So if you're only interested in providing some feedback on the core data elements, not on the enhancements, you could just focus on those. And the Excel file for demonstration project partners can see how it's aligned to all the minimum data standards that we have utilized. So it's not for public consumption. It's something that we share with you with the memorandum of understanding. And the MOU is just to kind of let you know that you're not required to adopt this. It's just, for us to provide some feedback and to hear from you about what are some of the things that we need to take into consideration. The last thing that I want to mention, and I know there's a couple of comments, some of which are just to me, so that I can speak to those, is that our team is also undertaking integrated health workforce planning that's interprofessional. It focuses on the primary care sector, and it's focused on Toronto. And so we know that, again, that's a certain scale that we're doing. But the development of the minimum data standard has been very much informed by the 7 years of work that we have been doing in Toronto on planning, which includes midwifery and medical laboratory technology and family medicine and nursing and other professions, physiotherapy. So this is very much grounded in what is it that those who are required to do planning need to have at hand in order to address particular questions. So again, it's been this very much dynamic process of going back and forth between what we hear from you, what we know from the literature, what we are informed by this planning process. And so it's been a minimum data standard that has been developed in a very robust way. Questions, and just so that we can break out at noon. And I think, Audrey, you've got things set up for all the breakout rooms. That's great. So just some logistics. The slides are going to be made available, as will the presentation and the feedback from our different partners. So we'll be putting that together in a modular way that will be available on the CHWN YouTube and on the CHWN website. If you haven't gone to check out the CHWN website, please do so. Raha and I have been doing lots of different enhancements on there. And then we're also happy to have follow-up conversations with you and develop the website with other resources that you have. So that was one set of questions. And yes, I know that some of you may have to step off for meetings. We understand that. So maybe what we will do is now we will set up into the breakout groups. Each breakout group will have one of the members of our team, one or more members of our team. We're just going to be recording some of those just for our consideration, not for public consumption. And yes, and Raha, before you sign off, has also put in the Canadian Health Workforce Conference. We will have another set of dialogues at the end of November about where we are at with the latest developments. And also there are opportunities for people to submit abstracts, sponsor a session or subplenary or workshop. So please have a look at that. Okay, so we're going to break out for about 20-30 minutes. We'll come back and do some wrap up. Thank you again to Kelly and Adam for your presentations. And Audrey, you can take it away.